extension is going to be more torque. So early on, especially if it's acute, I like to put them in a little bit of flexion, have them extend their wrist, and then I tell them just hold that. Okay, what's a positive test? Pain. These are all pain provocation tests. Okay, so resisted wrist extension. Okay, if I'm gonna look at the other one, overstretch. Okay, I start elbow extended, slowly move them into wrist extension. Okay, what's my positive test again?
Pain.
Pain. Okay, pain over that lateral condyle. So I'm either resisted or I'm passive overstretch for wrist extension. Wrist flexion, I'm sorry, wrist flexion. Stretching the extensor. Wrist flexion, stretching the extensors. Thank you. Okay, this is where my patients really like to let me know how much they love me. I tell my patients, go ahead and flip me the bird. Yeah, we did that really automatically well. Lots of late feelings from being a student, huh, Derek? Hold that finger at a stance for me. And then you're just resisting third digit extension. And I went up a little too fast. Is that? I don't know. There's a reflex. Give your boss the bird. Okay. So that's lateral epicondylitis. So I'm either wrist extension, third digit extension, passive wrist flexion. Stretching the extensor. Okay. All three, I'm looking for pain provocation. Weakness secondary to pain could be the other possible finding as well. So what you see a lot, so someone that's really highly irritable acute, you're going to put them into resistive wrist extension. Do you think you're even going to have to resist extension? No. Even sometimes to extend that third digit, it's going to be painful. Okay, and then you put them in that passive overstretch, and that's going to be painful as well. So that's a really nice cluster just to really quickly utilize palpation over the lateral epicondyle and utilize those as a really solid differentiator between radial tunnel and lateral epicondylitis. Any questions about that at all? So if I'm going to test for medial epicondylitis, what am I going to resist?
Flexion.
Wrist flexion, right? Put them into wrist flexion, hold, hold, hold. What's my positive test?
Pain.
Pain. And then the opposite of that, put them into passive wrist extension. Okay, and again, pain is the primary indicator there. Any questions about those?
What was the last one you were doing?
Passive wrist extension. So, here. Because if I'm extending the wrist, what am I stretching?
Flexors.
The wrist flexors, right? So it's just a passive overstretch. Okay, there's a question there. It says histological studies indicate that epicondylitis are most likely not that of an acutely inflamed tendon, more likely chronic in nature due to repetitive microtrauma. How may this knowledge affect our treatment? Okay, so tendinitis versus tendinosis. So aggravating factors, definitely. How am I going to treat those differently? What am I really focused on if it's a tendinitis? Acute onset. Inflammation. Getting it calmed down, right? If something is now becoming degenerative in nature, we know from those histological studies I referenced from our lecture that we actually see disorganized bundles of collagen. We start to see degenerative parts of a tendon in that common extensor tendon in people with a tendinosis. So what am I going to do to affect that? And how would I treat it differently than the inflammation? Jared?
You can build it up. Acute tendinitis, you want to calm down and then progressively add load back to it so the tendon becomes more robust and more accustomed to loading. Maybe you alter whatever they're doing that is the repetitive stress that caused the acute onset. But acute tendinitis actually resolves really quickly if you manage load appropriately. Tendinosis, because it's a degenerative change in the tissue, it's going to be a lot longer road to recovery, and it's going to require a lot of progressive overload. The histological studies that he's talking about, they use an analogy called a donut in a donut hole. So if you look at a donut, the outside of the donut is the healthy tendon tissue, and the hole in the middle of the donut is the degenerated tissue. So you have lots of little plugs, essentially donut holes taken out of the tendon, and those don't heal. Those don't get better, no matter how much you strengthen them. You have to make the rest of the tendon, the rest of the donut, bigger and stronger and more robust, and be able stresses that are imparted onto it. So you actually have to think about the tissue time to build up and make up